Dr. Alankar Tiwari. He will be talking on management of diabetes after 2023 and what are major takeaways. Please, Dr. Alankar.
A very good evening to all the eminent clinicians who are present here physically and also virtually. And I first of all thank Dr. Alok Singh sir for providing me this opportunity to be a part of this fabulous academic event here. And I will be discussing something about a slightly apart from the league, that is about the diabetes, but we are all well aware of the fact that diabetes is one of the most common cause of cardiovascular morbidity and mortality. So something about the recent or the current management of diabetes in year 2023 and also the advancements which we are going to have in future. So something about the gravity of situation, that is the burden of diabetes which we are having in India. In currently approximately 80 million people are living with diabetes in India, that is around 8.8% of our total population. And as we have just surpassed China in as context of population, also in the population of diabetic patients also we are going to be number one in the world. So 1 in 7 diabetes patient in the world is an Indian. And the upswing continues with the twin epidemic of obesity and diabetes. So by year 2025, the number of cases with diabetes is going to be around 82 million. And the sad part is that almost 50 million people are still undiagnosed. So long-term glycemic control is very essential to improve the outcomes, because 1% decrease in HbA1c, it translates to around 43% decrease in the lower extremity amputation or fatal peripheral vascular disease, 37% decrease in the microvascular diseases, 19% decrease in cataract extraction risk, 16% decrease in the heart failure, and 14% risk in myocardial infarction, and 12% decrease in the risk of stroke. So you can see the slight decrease in HbA1c, or vice versa can also occur, like our increase in HbA1c or uncontrolled diabetes can lead to so many micro as well as macrovascular complications. Cardiovascular disease is the leading cause of death in type 2 diabetes, and these are the various forms of cardiovascular disorders which we are having in people with diabetes, and like sudden cardiac death, acute MI, stroke, heart failure, and other. Now, steps for optimizing diabetes management. So first of all, we have to identify those people who are at risk of developing diabetes in future. Then testing those who are at risk, setting the goals for those who are already diagnosed, and then providing the proper management treatment, and then assessing them for the complications and following up. So first of all, we will have a look around the types of diabetes. So mainly we have 3 types of diabetes in our population. Majority is type 2 diabetes, then there is type 1, and also the gestational diabetes. And these days all these 3 types are spreading and increasing in incidences very much. Also type 1 diabetes and type 2 diabetes in young population also. So we are seeing the patients of elder like 15 years, 16 years, 20 years who are suffering with type 2 diabetes along with obesity. And the incidence of gestational diabetes has also increased quite high in the recent few decades. Now, what are the symptoms of diabetes? We are all aware of the facts that we have these osmotic symptoms like frequent urination, unexplained weight loss, extreme fatigue, feeling very thirsty, slow healing of the wounds, tingling or numbness sensations in the hands and feet, blurry vision, sexual dysfunction, or feeling very hungry. And most of the time, many of these symptoms are not present in the patient. So we have to get checked up every year, especially in those who are at risk, who are having a family history of diabetes, or who are above the age of 35 years. So the quick fact is that many patients with diabetes may experience no symptom at all, and we have to get checked, and that is the screening is the most important factor to get diagnosed early. Well, now what are the risk factors for diabetes? obesity, overweight is very important risk factor. And then the central obesity, which we Indian are very much, we are having a lean obesity type of body phenotype, which is at risk of developing diabetes. So we Asians are at risk of developing diabetes. The central obesity, physical inactivity, sedentary lifestyle, and unhealthy eating habits, family history of diabetes. Patients who are already in the pre-diabetic stage, they are very much prone to develop diabetes, and those who are more than 35 years of age. So screen family members of existing diabetes patients on a regular basis. On ideally annually they should be screened. Other risk factors are like hypertension, dyslipidemia, persons on diabetogenic drugs like steroids and others, like history of premature vascular disease, tuberculosis, history of gestational diabetes mellitus, women who have history of PCOS. So screen the women who have history of gestational diabetes mellitus, who are obese or who are having history of PCOS in past on a regular basis. So more the number of risk factors, higher is the risk of developing diabetes. Now, test those at risk. How? First, the test to confirm the diabetes. The very important and the very commonly employed test are fasting plasma glucose, then the OGTT, oral glucose tolerance test, which is the gold standard of diagnosing diabetes even with the current advancements, and especially in the patients of gestational diabetes or who are like in the borderline equivocal range. Then the random plasma glucose test and the HbA1c test. Now, using the IDRS, that is the Indian Diabetes Risk Score for screening, it uses the simple, safe and inexpensive measures and can help in cost-effective screening of our diabetes. Also, it would be helpful in selective screening instead of the universal screening. So, these are the various parameters through which we advise the risk for Indian diabetes risk. The low risk, if the number is between 30, those who are between 30 to 50 are at moderate risk, and above 60 is the very high risk for developing diabetes. So these are the tests to confirm diabetes and pre-diabetes, and these are the normal ranges. Like fasting should, if above 126, 2-hour post-prandial glucose after 75 gram oral glucose, more than 200, or A1C more than 6.5, or any random plasma glucose more than 200 is labeled as diabetes. So what next? If patient falls in the category of pre-diabetes, then repeat the testing every 1 year. To prevent cardiovascular disease, screening for treatment of modifiable risk factors like obesity, hypertension and dyslipidemia. And to prevent the progression of diabetes, we should have intensive diet control, physical activity, and weight loss, targeting a loss of at least 7% of body weight. In some situations, depending on the person profile, we also give the metformin therapy if BMI is more than 35, age is less than 60, and women with prior history of gestational diabetes. Now, steps for optimizing diabetes management. Fasting plasma glucose, OGTT, A1C and random glucose, they should be used as a diagnostic test. Normal people should be tested every 3 years, and those with pre-diabetes should be tested annually. And strategies for preventing diabetes and CVD should be undertaken for individuals with pre-diabetes. Now, setting the goals for those who are diagnosed. So these are the glycemic targets for the people who are living with diabetes. The fasting blood glucose should be between 80 to 130. PPBG should be less than 180 and A1C should be below 7. This is according to the American Diabetes Association. And this is also the approach for individualization of glycemic targets. Like in elderly patients, we usually keep the A1C target around 8. We do not advise very intensive or strict sugar control in those patients. And on the contrary, in patients of gestational diabetes mellitus, we keep a very strict glucose control, like the PP should be below 120, fasting should be below 95, and A1C should be around 6%. So we have to individualize or tailor the approach and goals according to the patient profile. Now, newer technologies have emerged in the field of diabetes management, also in the monitoring of diabetes, like use of self-monitoring of blood glucose and the continuous glucose monitoring or ambulatory glucose profiling for the monitoring of blood glucose levels. So this is they give a concept of time in range, and it is somehow a better or an advanced technique to monitor the blood glucose control over the period of time than the A1C. So through the CGM or continuous glucose monitoring, we have a real time monitoring of the patient's blood glucose level, and also the retrospective analysis and management of the diabetes. So with the advent of sensor augmented CGM and CGM assisted prompt therapy, there has been a promise of alarm based prevention of hypoglycemia in patients of, especially in patients of type 1 diabetes who are on pump therapy. Real time CGM, it appears to be a useful tool for decreasing time spent in a hypoglycemic range in people with impaired awareness for hypoglycemia. Now the steps for optimizing diabetes management and providing the proper treatment. So how to manage the diabetes. So these are the 4 major pillars for diabetes management. The most important is the lifestyle management, as the Manoj Gupta sir has already mentioned about the lifestyle management for management of lipidemia, dyslipidemia. So similarly for the diabetes also, lifestyle changes, weight control, diabetes education, and then comes the pharmacotherapy. So lifestyle changes: advise your patients to perform at least 30 minutes of the aerobic exercises daily, resistance exercises, reduce the sedentary time, increase the physical activity, individualize a diet plan for each patient. The portion sizes can be modified, then restricting the food items. So instead of restricting the food items, moderation is the key for current diabetes diet management. And advise to quit smoking or any kind of addiction. Now, diabetes education is a very important part. Half of the work is done if we are properly educate the patient regarding the diabetes management and also the self-care of diabetes. So, making patient-centric structured self-management education is an integral part of the care of people living with diabetes. So, whom to offer the patients along with the family member, when to offer, around the time of diagnosis, and it should be an ongoing process. And what to offer, the components of diabetes education, understanding the diabetes around the lifestyle modification, the importance of glucose monitoring and other things, and how to offer using an appropriately trained multidisciplinary team of doctor, educator, individually or in groups, using the techniques of active learning adapted to personal choices, and using the modern communication technologies, various apps which are available nowadays. Now comes to the pharmacotherapy. So these are the various group of drugs or anti-diabetic drugs which are available currently with us. Metformin, sulfonylureas, thiazolidinediones, alpha-glucosidase inhibitors, GLP-1 receptor agonist, SGLT2 inhibitors, DPP4 inhibitors, and insulin therapy. So what to choose and how to choose? So this is the ominous octet which causes the pathogen, which is behind the pathogenesis of type 2 diabetes. So these, whatever the drugs available with us currently, they all target these ominous octet, one or more of these ominous octet. So the decision cycle for person-centered glycemic management in type 2 diabetes. This is a comprehensive medical evaluation and assessment of comorbidities. So the goals of care, in current scenario, the goals of care is not just the glycemic control, but also optimizing the quality of life, giving a good quality of life, and preventing the complications of diabetes. So cardiovascular outcome trials, it is very important because nowadays we all know that cardiovascular diseases, they are a very important risk factor for diabetes and causes morbidity and mortality. So CVOT trials are very important, and it has caused a paradigm shift in the current management of type 2 diabetes. So all the drugs which are available, we have a CVOT trial, and only after that we are very assured to use these drugs in the patients of diabetes. Now these are the profiles of various anti-diabetic drugs available these days, like SGLT2 inhibitors, GLP-1 receptor agonists, and what to choose and how to choose. So how to start the therapy in a drug-naive patients, or those patients who are already on the various type of anti-diabetic therapy but still not controlled, who are having other comorbidities like cardiovascular diseases and hypertension. those patients who are very elderly, like about the age of 70 years, 80 years, those patients who are having any other things like CKD, hypertension. So we have to individualize the treatment approach. Now something about the insulin therapy. So these are the various regimens, insulin regimens, which are available with us. So multiple daily long-acting insulin and short-acting insulin are available. Then something about the continuous insulin infusion regimens like hybrid closed-loop technology, insulin pump, and pump with automation. So what to choose and how to choose, we won't go into the details of this. So something about the newer technologies and newer insulin analogs which are available with us. So one such breakthrough is the development of ultra long acting degludec and once weekly administered long acting insulin analog icodec. So we will be having icodec with us probably by the next year in 5 to 6 months, the once weekly insulin. It will be a revolution in the field of management of diabetes, and also the availability of the Technosphere inhaled insulin, that is Afrezza, that is the inhalational insulin. So the latest in diabetes management armamentarium, some molecules which are available or going to be available recently very soon are tirzepatide, which is dual GLP-1 GIP agonist, also called as twin creatine, which is first in the class, FDA approved for treatment of diabetes and also potent weight loss properties. And teplizumab, which is a humanized anti-CD3 monoclonal antibody, which is first in its class and approved to delay the onset and progression of type 1 diabetes. Then orforglipron, which is an oral non-peptide GLP-1 receptor agonist. It is in developmental phase for management of diabetes and obesity. And then cagrisema, which is the combination drug including the semaglutide and cagrilintide, which is an long-acting amylin analog. So it is also in the phase 3 trial for diabetes and obesity management. Now, assessing the complications, we are all well aware of the various
Dr.
comorbidities
Alankar,
and
please try
complications
to
of
sum up your slides.
complications and cardiovascular disease and risk management. So, and finally referring the patients to the proper referral centers who are having various comorbidities. So that's all for the day. Thank you so much for the patient listening.
Thank you, Dr. Alankar Tiwari, for your nice deliberations. Now